Okay, so I will focus mostly on enabling fast reconstructions for free-running acquisitions as presented by Professor Matthias Stuber just before, and you will see some concepts that were presented this morning throughout my presentation. So as mentioned, the state-of-the-art MRI, so whole heart or coronary MRI, is quite cumbersome because you need to plan your acquisition according to a recorded ECG, so they do not blurred by motion. You also need to place a navigator to correct for respiratory motion. So this results in a quite long and complicated planning. So in free running, you want to basically be in one click acquisition. So you want to have a completely isotopic 3D coverage of the heart and then continuously acquire information irrespective of the underlying motion. The way that then you reconstruct free running data is twofold. You can use the interleaved superior inferior projections that basically record a state of motion throughout the acquisition to recover a respiratory and a cardiac curve, and then respectively reconstruct your image in the different cardiac and respiratory phases so that you have a dynamic whole heart volume. Or you can have a faster reconstruction that is in line, and this basically takes the same self-gating readouts, but extracts similar motion consistent information in a data-driven way. And this is the SIMBA reconstruction. So then basically in less than a minute, you have an image at the scanner that gives you information about the whole cardiac anatomy before the offline functional information that you get from the free running 5D reconstruction. So the way that SIMBA works, it takes the same self-gating readouts that you use to extract respiratory and cardiac curves, but it uses this to create a sort of motion matrix that then is reduced in dimension using PCA. And finally, you cluster this into different groups by using the k-means approach. And so by assuming that in the largest cluster, you have the information in one of the resting phases, you can then reconstruct an image that is static but gives you the whole information of the cardiac anatomy, and which is especially important in congenital heart disease. So currently at our institution in CHUV, we are acquiring this routinely to assess congenital heart disease, especially in pediatric patients, with the use of femoral enhancement. So the protocol, thanks to this, was reduced to basically less than 30 minutes, in which we have anatomical scans together with flow to assess both anatomy, function, and flow at the same time. And this basically accounts for a very large data set of more than 100 patients. This basically is accompanied with having the SIMBA reconstruction in line, but the 5D reconstruction is still something that we have to do offline and takes many hours. And so this can kind of hinder the clinical translation and workflow. So the question of my PhD project is, can we further improve the SIMBA reconstruction to be closer to the 5D reconstruction and then still taking lower computational times to improve clinical translation? So the first thing is to extend what we have in terms of data performance, because if you think about the SIMBA reconstruction right now, we have only one image that uses one group of motion consistent information, but we ignore all the rest. So we're quite data inefficient compared to the amount of information we acquire in a free running scan. So the first thing is, can we use all of these other motion consistent states to improve our image quality and have more diagnostic value? So we want to achieve this by basically using the input of different SIMBA clusters as motion state in a compressed sensing workflow. So basically the SIMBA clustering becomes a dimension of compressed sensing, and we regularize over this. But of course, since we have no control over the different phases that are extracted in this data-driven type of binning, we want to correct for potential deformations using non-rigid motion fields. So this final reconstruction compared to the original is much sharper, and also we have better delineation of the cardiac anatomy. You can see here as with the zoom on the valve or on the coronary arteries. And also compared to the 5D reconstruction, we have similar image quality, but still this is much faster in terms of image reconstruction. So this is something that, although we only have static information, our anatomical images are quite good. This is another case of a 1-year-old patient. So we're talking about structures that are very, very small, even below the resolution of our acquisition. But thanks to this approach, we're able to recover the detail and have very good image quality at the end, comparable to the one of the dynamic image quality from the 5D. So to summarize, we are able with this framework to better use the information from a free running acquisition by using the concept of the Simba clustering as a dimension compress sensing. And by applying our rigid motion fields, we correct for deformations that we have no control over when we apply this type of clustering. But of course, this is with thermoxetol, so it works really well because we have this information extracted from the superior inferior projections where we can really track the position of the heart thanks to the high signal from the blood. So the goal is to then translate it to non-contrast acquisitions. So if you see at how Simba performs right now on non-contrast data, for example, with these FIS acquisitions that were presented also by Matthias and Chris this morning, we are able to get a good image quality in terms of sharpness, but still we are lacking robustness. So for some cases it works really well, but for other cases it doesn't work because of other factors that come from the MR acquisition scheme. So a way that we can basically improve this in terms of the precision of extraction of motion consistent data is by using the piloton. So this is completely decoupled from our acquisition scheme. And so when we have a reconstruction that works for one of these data sets, it could work for potentially all the other free running acquisition, irrespective of the underlying contrast, which is quite powerful. So this is some preliminary data of how our acquisition performs in two different types of contrast. So in the, say, standard ferromoxetol that we use clinically, we're able to reproduce similar results compared to the original technique. And also in our native contrast, so this is a volunteer acquisition, we're able to have better delineation of the myocardium. Still, we have many steps that need to be done. This is very preliminary. So, of course, we need to improve in terms of frequency selection also from the information of the piloton, because we have a lot of information that comes and a lot of things that can also pollute the piloton signal. So it's not as easy as it may seem, as Mario explained this morning. And of course, when you talk about acceleration, and it was discussed by Thomas's presentation, deep learning is definitely a solution that should be investigated. It could be either through motion extraction, so we can replace what we use in terms of data-driven selection through some sort of deep learning approach, especially if you want to have a Simba reconstruction that gets also functional information. And when it comes also to compress sensing takes a long time, especially when it's iterative and with data sets that are so big, such as the free running ones. So we should also think about reducing computational times through physics-based or enrolled models, as Thomas presented. So, oops. Thank you very much for your attention. If you have any questions.